Hello, everybody. Thank you for coming tonight and taking time out. Hopefully, this will be productive. And I always say, any education and knowledge is power. So hopefully, you guys will learn something from me. I'm Dr. Atty, and we're going to have Dr. Moisi, and he can probably introduce himself later. He's a neurospine surgeon. We work together very closely. So it's been a wonderful team between the two of us. And most of you probably seen either me or Dr. Moisi. So again, we're going to answer questions after the lecture. First, we'll do a little bit of a talk and talk a little bit about chronic pain. And I'm going to try to keep it informal. But if you have questions, just write them down. I'll be happy to answer them after. Anything you want to say more before we start?
No, I'm pass the mic over to you.
Okay. So I have a bunch of slides. Again, I'm a physiatrist, which is a specialist in physical medicine rehabilitation. And I'm also board certified in pain medicine. So that's my subspecialty. I work at a comprehensive pain specialist. I love teaching. I've been teaching for over 20 plus years at Michigan State University. So go green. I hope there's no Michigan fans around here. So I'm an assistant clinical professor at Michigan State. I teach the fellowship, which is spine and pain fellowship. So I'm a director also of that at Michigan State University. So sometimes when you're in my office, you'll see medical students, residents, and fellows, and I love teaching. So again, this is going to be hopefully a good education and some more teaching. So we talked a little bit about what a physiatrist is. We're going to talk a little bit about what causes chronic pain. Chronic pain is very difficult because there's many things that can cause chronic pain. So again, I'm not going to be able to cover all that in one lecture in half an hour. What makes it better? We're going to talk a little bit about that. And then we're going to talk about different treatment options. And the beauty about treatment options is I've been doing this for 31 years. I can tell you what I do now is night and day compared to kind of tools I had. When I first started, I didn't have a lot of tools to help people. So now I have a lot of tools, and I'm sure, Dr. Moisi will probably tell you the same thing. We have a lot more tools we can help, but people still don't know about all these tools. So hopefully today you're going to learn about some of these tools and how do we use them, and is it an appropriate tool for you? So we'll talk about that a little more. So back pain is the number one cause of chronic back pain. So if there's anything we always hear and see in our office, me and Dr. Moisi, it's spine, neck pain, upper back pain, lower back pain. That's very common. Other type of chronic pain we see is a lot of joint pain and arthritis, and then also headaches. So those are the most common reasons. But everybody's going to experience back pain in your lifetime. Now, unfortunately, a small percentage of people have repeat back pain and develop chronic back pain. What's chronic? Anytime you have pain more than 3 months or 6 months, and it continues, that's chronic pain. So a lot of us have acute back pain. We get a little bit of a strain, and it goes away after a week or two. But we're not talking about that. We're talking about people who have pain that continues to bother them. And then what happens? You have difficulty functioning, you have difficulty sleeping, and it leads to emotional pain. So chronic pain, and we're going to talk about this, is not just physical pain, but it's also emotional pain. So I always want, when I talk about pain or anything I educate, I want to present the patient. So I want to talk to you guys about a patient, 60-year-old male who's had at least 15 years or more of chronic lower back pain. This patient had moderate to severe degenerative disc disease. I will talk about a little more what that is. That's basically arthritis, pretty bad arthritis in the disc, in the spine. And this gentleman, 6-year-old, had also what's called a pars defect, which the parts of the back area, the bones, you're born with weak bones, and eventually they can break. And when they break, basically the disc collapse and they move forward. So imagine you got these discs with a lot of space. Now they collapse and move forward. What happens to the nerves that come out of here? They get crushed. So this person developed bilateral L5 radiculopathy with foot drop, and he couldn't pick up his feet very well when he walks. And then eventually he tried every conservative treatment. He had to have surgery January 27th of 2020. Well, this is his screws in his back with the fusion. And Dr. Moisi can probably talk to you more about this, but this is a front view, basically taking a picture this way. These are the 4 screws. And this is a side view showing the screws going in the bone and a disc spacer. So it opened up the hole where the nerves come out. So they're not crushing and damaging the nerves as much. And you guys all know this patient. This patient standing right here. That's me. So you probably heard my story a little bit. Now, why am I telling you this? Because I think it relates to every one of us about chronic pain, and it made me understand a lot more about a little bit what you guys go through. Not all of it, but somewhat. And I always told my wife, thank God, God gave me something I know a lot about. But even me who knew a lot about it, I learned a lot about it. And I learned a lot to hopefully sympathize with my patient a little better. Not that I was a better doctor all of a sudden, but I think it makes me understand what you guys go through a little bit. But even me going through the medical system, it was not fun. I saw 5 surgeons, and they were all friends, and I knew of them, and I was able to get in with surgeons quick, get my MRI. But 2 of them told me something that I wasn't very happy with, didn't make sense to me. One of them told me, just live with it, because you don't take pain medication, you're good. I said, no, I don't take pain medication during the day, because I put a lot of big needles in your spine, and you don't want me half asleep or not thinking right about when I put needles in your spine. So I told him that's why I don't take pain medication. I did take some pain medication some nights because I couldn't sleep because of pain. So it affected my function eventually. I had the surgery. I am better. The next question all my patients ask, and I'm sure you guys asked Dr. Moisi, are you going to fix me? And I told him my surgeon was amazing, but he didn't give me a new spine. He didn't fix me. So we don't fix people. We'll talk a little bit about that. We manage pain, especially chronic pain. So it's like having any chronic condition, diabetes, high blood pressure. We don't get rid of high blood pressure. We don't get rid of diabetes, but we try to make it better. So we'll talk a little bit about that. And I'm sure you guys hear me talking about that in the office. So pain is a very significant health problem. And it's the most common reason we see actually doctors, believe it or not. Not diabetes, not high blood pressure, not colds. It's the most common reason. And it costs a lot of money. It costs anywhere from 560 to 720 billion with a B a year. That's a lot of money. So what if we can treat it better and reduce that? And also, almost 52 million or 21% of American adults have chronic pain. So 1 out of 5 people have chronic pain. So again, it's not uncommon. You're not unusual. We do have quite a few people who have chronic pain. So again, you can see here that pain actually outnumbers diabetes, coronary heart disease, stroke, cancer. So again, 1 out of 5 people. And it doesn't discriminate. It doesn't discriminate against age, sex, race, poverty. So if you're wealthy, it doesn't mean you're going to escape chronic pain. Okay? So again, it affects everybody. What are the common myths about chronic pain? This I hear a lot. Well, people don't know what to do about chronic pain. No, we do have some standards we try to follow. Again, not every tool fits everybody, but there are tools. There are better tools, like I said earlier. We always have fear of addiction of pain medication. Pain medication, if they're used under the direction of a doctor and appropriate, I can tell you, I've been doing this for 31 years, and I prescribed a lot of pain medication. 98 to 99% of my patients do not get addicted to medication. They don't want to be on medication, but some people have to. Just like you have to be on high blood pressure medication or be on insulin for your diabetes, sometimes you have to be on pain medication. I'm not saying that's the best tool, but it's one of the tools. A lot of people, their fear of addiction is not really addiction, it's more dependence. When they stop their medication, they have withdrawals. It doesn't mean you're addiction. Addiction is when you abuse medication and you get high on it. But if you're following the doctor's rules and the rules we follow, you'll be okay. Again, we also talk about, people with chronic pain say, well, my doctor said I got to live with it. Well, nothing against your family doctor. They're great at high blood pressure, diabetes, but they don't understand pain. I had barely one lecture in medical school about pain. I learned pain because of my specialty. But we, as doctors, we don't get taught about pain. And pain was thought of very different many years ago because we didn't really understand it as well. We have a lot better understanding about chronic pain and how to manage it. So we also talk about the psychology. A lot of people say, no, it's all in your head. Well, it is in your head because without a brain, you wouldn't feel pain. But it's not in your head. Yeah, it's not just in your head.
Yeah, it's in your head.
You know, but the head is connected to your spine, is connected to your joints, connected to your nerve. So they all go together. So yes, you can develop psychological issues because of chronic pain, but doesn't mean the psychological issues is what's causing your pain. So two different things. Also, I hear a lot about, hey, I have pain, I can't do anything because I'm going to damage my disc. Well, that's not true. When it comes to chronic pain, a lot of times we have a lot of fear and anxiety about moving because we're worried pain is going to cause pain. Well, when you have a broken pain and a sprained ankle, yeah, that makes sense. That's acute pain. By the time we get to chronic pain, most of the areas have healed. But again, damage doesn't equal pain. So I always tell people, I use the example, if you hurt, that's going to happen sometimes with chronic pain. But you're not harming anything. You're not damaging anything. So I'd rather you move. Don't have fear of movement. I'd rather you move as much as you can. I'm not saying go crazy and have a lot of pain, but do something, whatever that be. And we'll talk about a little bit about what can you do. And one of the things I can tell you, when I had pain, I was a little afraid to move because I was causing myself more pain. But then I said, why do I tell my patients to move and do certain things? So I started doing a little bit of yoga and a little bit of stretching because that's all I could do. It got so bad, that's all I could do. I couldn't exercise, I couldn't go to the gym, I couldn't play sports, but I did some yoga and some exercise stretching, and that helped me recover. But there's always something you can do, but you have to find it. Don't be afraid just because you have pain, because when you have broken bone, ankle sprain, that's a different kind of pain we're talking. But by the time 3-6 months, that area is healed, that you may still have pain. And unfortunately, that does happen. So again, we talked about we don't fix chronic pain, we manage it. So what is chronic pain? Again, we talked a little bit about anything that persistent pain. Some people use 3 months, some people use 6 months. I like the 6 months. Acute pain is when you break your bone, ankle sprain, goes on for 2-3 weeks, 4 weeks, 5 weeks, and goes away. Now, we're not talking about that. That's a different kind of pain. We're talking about pain that persists for 6 months or longer. It affects your function, your emotion, your life. That's the kind of pain. And again, there's different kind of pain. There's nerve pain, there's joint pain, there's mixed pain. And also pain doesn't come from one area. You guys know, I always talk to you about pain can come from your joints, can come from your nerves, can come from your disc. And there's a lot of different areas. My job is to figure out where's it coming from and to help you with that. So how do we measure pain? We really don't have a good way of measuring pain. We use that analog scale every time we ask you, because we have to, because insurance wants us, what's your pain level? And you look at me like 12 out of 10, 20 out of 10. I'm like, you're talking to me. It can't be that bad. Because this is what's meant for acute pain. When you break a bone, yeah, that's 10 out of 10. When your tooth is getting pulled and you have surgery right after surgery, that's maybe 9 out of 10. But unfortunately, we don't have a good way to measure it. That's the best way we know, but that's not a good way. Really, how we like to measure it is by looking at function. So a lot of times I ask my patient, what is it affecting? Can you sit? Can you stand? Can you sleep? Can you walk? Can you play with your grandkids? Can you work? So that's a better way of measuring pain. So a lot of times we ask that question. Why? Because this is our way of measuring pain. So if you tell me my pain is still out of 10 out of 10, and my pain is not any better, but hey, I'm sleeping better, I'm walking a little better, I'm happy with that. And most of you are happy with that. Most of you will tell me, yeah, I want to get my life back. And I know I've been there when I couldn't barely work and I was not enjoying my work, which most of you guys know I like to do what I do. When I wasn't enjoying it, I said, this is really bad, I got to do something. When I couldn't walk, I couldn't function, that's how we measure pain. So again, what is it? Are you having trouble walking outside? Are you having trouble socializing, playing with your kid? That's another thing. We sometimes avoid socializing and avoid being with other people because we're in pain. That's not good either. So how do we, again, the reasons we try to manage pain, because we talked about how it's debilitating, how, more medication now is better, because sometimes when you're in pain, you just want more medication. how you become deconditioned, you become weak, and it's a vicious cycle. When pain hits you, you stop moving, you get weaker, you get more pain, you get more depressed, you get more anxious, and it's a vicious cycle. My job and Dr. Moisi's job is trying to break that cycle a little bit. But also breaking the cycle, I'm going to talk about later, is up to you too. We're just the coach. If the player doesn't want to listen and doesn't want to play, we're not going to do very well. So a lot of times I tell people, I'm guiding you. If you don't want to walk down that road, I can get you there. So again, you got to remember that. So there's a lot of things we're going to talk about, how to get pain under control, and really rehabilitating the pain. When I talk about that, is start moving, start being active, start being a little more positive minded. Okay. And again, I'm not saying it's easy. None of this, what I'm saying, it's easy, because I've been through it, and I thought there were days I wasn't going to be able to work. How am I going to be able to support my family? And you guys know, like I said, I love being a doctor. So what if I couldn't be a doctor? That was depressing. So I've been there, but I also try to keep a positive attitude. Hey, if I do these things like I tell my patients, hopefully I'll get there. And it took me a while. It took me 2 to 3 months after surgery just to get back in the office. And that was not easy. Trust me, it was. But again, I had a good family. I had people looking out for me. I had good coworkers. I had a good surgeon. I had good therapists working with me. And getting that positive attitude really is really important. What we do. So again, who's treating this? Usually you're going to go see your family doctor first, and maybe he'll send you to a pain specialist. He may send you to Dr. Moisi. He may send you to a physical therapist. It's really important to follow on this. A lot of people say, I don't want to go see a pain doctor. All he's going to do is put a bunch of shots in me. I don't want shots. Or he's going to throw a bunch of pain medication. I don't want to get addicted. I don't want to go see that physical therapist because all he's going to do is make me hurt. And I don't want to exercise. I don't want to move. It hurts too much. Or I don't want to still go see Dr. Moisi because I don't want surgery. That's scary. And I've been there. There were days I didn't want to really do my exercise because it hurt too much. And I sure didn't want to see Dr. Moisi or one of his colleagues to do surgery on me because I've seen sometimes what happens after surgery. But I'm biased. I only see the bad cases. A majority of them do well. But again, he's not fixing you. I'm not fixing you. We're trying to manage you. But you also have to be part of it. You're the center of the team. We're just the coaches. So again, who specializes in pain? Again, pain specialists are anesthesiologists, physical medicine rehab, some of the neurologists, neurosurgeons, orthopedic surgeons, some even the psychiatrists, psychologists actually manage pain because we said some of the pain is emotional. So what's a physiatrist? What's a pain specialist? Again, I'm a non-surgical doctor. I don't do surgery, but I do procedures to help you with pain. I try to use a team approach. I try to use our physical therapist. I have a wonderful nurse practitioner. One of them is sitting there, and a physician assistant will help me. So I try to use my team. And sometimes I may send you Dr. Moisi, and he may give me an opinion what he thinks about surgery or no surgery. So we try to treat the problem. My job is to figure out what's your problem. Back pain is not a problem. There's multiple causes of back pain. My job is hopefully to figure that out. And we'll talk a little bit about how we do that. And then I'm trying to get you to function better. And I'm trying to treat you as a person. Sometimes, I see patients say, nobody even touched me. You're the first guy who touched me. I said, I don't know how good the other doctors, but I got to touch you. I got to examine you. Or they didn't ask me much questions. Well, I don't know. I have to ask you questions. Because how I formulate what's the diagnosis, what the problem is, and we'll talk about this by asking you questions, examining you, looking at all the tests you had. It's not like I have magic. It's not like I can just look at your MRI and say, hey, this is what's wrong with you. Let's do this. It doesn't work like that. And some patients get annoyed with me and ask a lot of questions too, but most of them don't. They're happy that somebody's caring about them. So again, detailed history, exam. I may look at your MRI. I may look at your EMG. I may look at your CAT scan. Again, MRI doesn't tell me the whole story. It's part of the story. A lot of people say, well, I want an MRI because I want to know what's wrong with me. That's not how it works. My history, my exam. And sometimes I may need the MRI to add to the story. Sometimes I don't. I also do injections that are guided. And guess what? Every injection I do, if it's guided, it's a test. And it's a treatment at the same time, but it's a test. Sometimes I do injections just for a test. I don't do it for a treatment because Now with this technology I have, which I didn't have 31 years ago, I can block a nerve or a joint, and then if you feel better while it's done, it tells me a lot. So a lot of patients come to me and said, well, if you had a shot, shots don't work. And we'll talk about that. What shot did you have? What did they do? I don't know. And so there's multiple things we can do. And again, there's multiple causes of back pain. So again, we want to treat the source of the problem and hopefully help you treat as a person and prevent the problem. So sometimes I tell patients, even if we can keep you where you're at, improve on it, and keep you from getting worse, that's probably the best we can do. Again, we talked about being comprehensive, using medication, physical therapy, sometimes alternative treatment, maybe a TENS unit, maybe massage, maybe a brace, maybe acupuncture, maybe cold laser therapy. And then we talked about the injection. And we'll talk a little bit deeper about ablations, peripheral nerve stimulators, spinal cord stimulators. How do you improve your function? I told you a couple of things I did. Yoga, stretching. I still do my yoga stretches every morning. And while I'm meditating, I listen to music and I meditate and stretch. I don't meditate by just sitting there. I like to do like a movement kind of meditation. And it helps clear my mind and relax my body. And also, you know, physical therapists are an important part of our treatment, but you have to listen to them. You have to learn from them and do what they tell you. I see many patients that, hey, I went to therapy 6 weeks, 4 weeks, they hurt me more. It didn't help. Okay, are you doing your exercises? No, they didn't work. Are you doing your exercise? No. Well, think of therapy, and you probably heard me say this many times, think of therapy like a class to learn how to exercise. These guys went to school a long time to learn how to give you the right exercise for the right problem. And if it's not helping, let them know. They can change things. Not everything fits everybody. Or if you didn't find the right therapist, go to the right therapist. Just like sometimes, maybe I'm not the right pain doctor for something. Maybe I'm not an expert in everything. So if you don't find somebody who can help you, find somebody else. Or ask around, or ask one of us. So sometimes it's the right therapist. It's not the therapy, it's the right therapist. So that's important. Aquatic therapy is another way of maybe doing something less extensive, less stressful on the joints. So pain management is a lot of things. It's not just one thing. So don't think of it, I'm going to go to the pain doctor and I'm only going to get a shot and that's it, I'm going to get pain medication. There's a lot of things we can offer you as tools. Again, I won't belabor medication. Most of you guys know about this. There's anti-inflammatory medication. There's all different ones. And we talked a little bit about opioids. I think opioids have a role, but we got to be careful. Not always more is better. Okay? They can be addictive to a certain point, but again, as long as you do it under the direction of your provider, your doctors, I think you're okay. But maybe not a long term. Maybe just to get you initially over the hump until we do some procedures or until you get your surgery and get better, and then you can be weaned off. So it doesn't mean just once you start on pain medication, you got to take them forever either. And that's the goal. We're going to talk about some of these procedures, hopefully, to get you off pain medication or reduce the amount of pain medication. So we talked about physical therapy, maybe doing massage, all the TENS unit. I won't belabor that. But really, this is important. If you're not doing your exercises, and you probably heard me this many times, if I just do injections on you, you're not going to get better. You're not going to get stronger. One of my mentors one time would say, I do functional injections. And I got all excited. I'm like, what is this guy doing that I don't know? And I said, what are you doing? He said, well, I do injections for people to function better. I said, okay, that makes a lot of sense. So don't think of just injection as I'm going to get my pain better, I'm going to be all better. No, even if it gives you 2 months, 3 months of relief, what if you can move better in those 2 to 3 months? You're going to get stronger. Your mind is going to get more power. You're going to feel better. If you couldn't walk a block and all of a sudden you can walk 2 blocks and you're walking your dog, you're playing with your kids, you're going to feel better. And that plays a lot into how you're going to improve down the line. So don't forget that. We talked about a little bit about meditation, yoga, tai chi, biofeedback. Sometimes you may have to see a psychologist, psychiatrist. If you're really depressed and anxious, you need to talk to somebody. They're a therapist. Sometimes you need therapy for the mind, just like you need to train your mind, like you train your body. And sometimes we need that. So when somebody mentions a psychiatrist, they're not saying it's all in your head, but pain is emotional. I've been there. My wife can tell you I was probably depressed in those 2 months I was sitting home. I wasn't working. But I didn't let that control me. Luckily, like I said, I had a loving family, close friends who visited me, kept me positive, kept me going, my kids. And that's important. So use, if therapy is your friends, if it's your church, if it's meditation, if it's a support group, whatever you do, I think that's important. Okay. Again, there's other drugs we use that are non-narcotics. They could be antidepressants, muscle relaxers, topical, antispasmodic. There's all different drugs we use. And again, the nice thing about these is they're not addictive, but they can be used to control pain. Just because you don't have a narcotic or an opiate doesn't mean there's not something else that can help. And so ask, whoever you see, hey, what else can I try that I haven't tried? Now we're going to talk a little bit about injection. So I told you how we use X-ray, we use ultrasound. Now I do what's called guided injection. 31 years ago, I used to do injections, but very limited. I used to call them a guessing injection or educated injection because I didn't have these machines to be able to tell me where the needle is going inside your body. Just like the guy who did my surgery, he was able to do it all through a scope. In the old day, they would have to cut your back pretty far, and Dr. Moisi will talk about this a little more. But now they do this minimally invasive surgery that allows you to recover a lot faster and hopefully less pain down the line. So just like that, injections do that too, because my injections are into areas that are very localized. I don't have to poke around. I'm not going to hurt you as much, and it's much safer. Plus, it's going to be diagnostic, so it's going to be a test. So it's safer, simpler, less painful, and I know what I'm getting at. And it helps me understand a little more where your pain is coming from. We can use local anesthetic, like numbing. We can use steroids. We can also use stem cell. Sometimes we do what's called platelet-rich plasma, which we take your blood, spin it, we take the stem cell out of there, inject it. Again, it's not for everybody, but for certain cases, this may be helpful. We do facet block, medial branch block. I won't belabor all the blocks, but while I'm talking about all these different injections, just because you had a cortisone injection, it doesn't mean you cannot have another injection in a different area. So if you had an epidural and that didn't work, that's more for the disc and the nerve. What about a joint injection or in the facet joint? What about tensor? What about a rhizotomy? What about sacroiliac? So again, just because you had a cortisone injection in your shoulder doesn't mean cortisone is not going to work on your back. I hear that a lot. Oh, I already had cortisone. Cortisone doesn't work on me. No. That was in a certain area, different problem, different area. Was it guided? Did your doctor do it under guidance? How am I doing on time, Stephanie?
Just keep going. I'll just add.
Yeah, I'll be quicker. So again, I told you, you get me talking about pain and something I'm passionate about, I can go for hours. My wife is surprised because I'm a very quiet, shy person, but this is what I love. So again, we talked about this, how we're going to use the guidance to deliver the medication, hopefully help you facilitate exercise therapy, help you with the diagnosis, and maybe avoid surgery. Sometimes we can do that. Sometimes we can't. But I think, Dr. Moisi will be the first person to say, hey, try those things, and then if those things don't work, come back and see me. That's what I love about Dr. Moisi. He's not quick to operate on you. Say, hey, try other options. Because sometimes we don't know what's work. Because you guys all the time ask me, is this going to work? How long is it going to work? How good is it going to work? I'm like, I don't know. But I can give you an average. 70 to 80% of the time it does work. It can last usually 60, 70% of the time, a few months. But I can't predict the future because if I could, I don't know. So again, we have to understand that this is medicine. Medicine is a science. It's an art. It's not a definitive. You're not a car. We don't replace parts. We don't fix parts. So we're all unique. Thank God. So this is like an epidural. This is the nice thing about fluoroscopy. I can put it directly where the nerve and the disc. Unlike the old days, I would do a gunshot approach, throw it everywhere, and hopefully I land somewhere. Now I'm using a laser target. I can get it exactly where I want. And that helps me also understand where your pain is coming from besides treatment. So that's the nice other thing about that. We talked a little bit about how it could be from the facet joints. And these are the little joints in your back And sometimes by blocking these joints or injecting in the joint, it allows to understand where the pain is coming from. So I don't know what joint, and so I can do a test injection. And if the test injection works, then I can go and do their ablation. That's going to last longer, or sometimes I may have to put a steroid in there. So I can do this anywhere in the spine. So it may be a sacroiliac joint problem, which is more common in women. So maybe injecting that joint maybe makes me understand where the pain is coming from, because that's the best way I can diagnose it. I cannot diagnose it by X-ray, CAT scan, or MRI. But if I inject it and you feel better, I know where the pain is coming from. Ultrasound can be used for nerve block, joint injection, shoulder, knee. Again, the beauty of it, I can put exactly where I need to. I can be very precise and less painful and hopefully get better result. And if it doesn't help you, I'm going to say, well, there's probably something more going on. We're going to talk a little bit about ablation, a spinal cord stimulator. Radiofrequency ablation is basically introducing heat signals or thermal energy along the nerves in the spine and hopefully get 6 to 9 months or sometimes up to 2 years of relief. And it can be repeated as long after 6 months anytime, or when your pain comes back. It can be done anywhere in the spine, sacroiliac joint, knee joint. We can even do it for the knee. And again, it's introducing heat to the nerve to block signals in your back that go to the brain. So basically, I'm blocking your signals that go from the nerve pain in your back up to the brain. Again, it's going to last 6, 9 months or 2 years. It's an injection, very minimally invasive. It's really no different than other injection. I use guidance, so I know exactly where I'm going. And again, 80% of the people respond. It can last up to 24 months. I've seen it even longer. I've seen people go on for years. But usually the average of studies, what we see is 6 to 9 months. And again, there's always improvement in pain. It's not going to take your pain to zero, but most people are happy if it takes 50% or better. I can tell you, my patients will say, I'll tell them 50% better. Like, hey, I'll take that any day. And most people respond. Here's a needle, an X-ray showing you where I put the needle. Besides looking at the picture, I do some other nerve testing. Now we're going to talk a little bit quickly about spinal cord stimulator. I want to thank Boston Scientific for getting us all here. They're one of the companies we use commonly to spinal cord stimulation. Basically, it's introducing thin wires in your spinal area. And we think of this treatment as a drug-free treatment. That's the beauty of it. We're not using chemicals. So it's basically like getting an epidural. So instead of me putting steroid and numbing in the epidural space, I can put a needle in your back and put a thin wire through it and put it in the epidural space and stimulate those nerves, again, to block the pain signals from going from your back to your brain. So if I can block it here, you're not going to feel the pain. So it's really the science behind it. In 31 years, I've seen it. It's incredible what they can do with it now. 31 years ago when I started, I didn't use it because it was so poor. But in the last 15, 20 years, we've been using it a lot more. Probably in the last 5 years, we've been even using it more because the technology is just amazing. But again, it's not for everybody. You got to try out some other things. Usually, I want you to see Dr. Moisi, make sure he can just do some surgery and help you. And if he says, hey, go ahead and try it, then we'll trial it. And then if the trial goes well, I send you back to Dr. Moisi and he puts in the permanent. But even the permanent is not permanent. Okay, it's reversible. And then the nice thing about it is you get to try it before you buy it. So we put it in, we leave it in for 7 days, you get to try it. And if you're functioning better, your pain is better, you're using less medication, that's how I know it's working. And then if it's working, we pull out the wires and I send you Dr. Moisi. Who's a candidate for this? Somebody who's had back surgery or he's got chronic pain with nerve pain. We've tried injection, we've tried therapy, we've tried medication. Nothing is working. Or you've had surgery and the surgeon says, no more surgery, why don't you try this? It can also be used for diabetic peripheral neuropathy. People have bad nerve damage from diabetes in their feet. Or there's another syndrome. It's basically called complex regional pain syndrome. Don't worry about the name. Basically, if you have nerve damage in your feet from trauma, from broken bones, the nerves become very hypersensitive. We're able to calm these nerves with a spinal cord stimulator. It is covered by insurance, but it's a process because it costs a lot of money. Insurance is not just going to let us do something that costs a lot of money until we run you through the process. But most of the time we get it approved. We talked a little bit about how it works using electrical activity to override pain. We talked about how the trial, if it gives you 50% relief, improving the activity, reducing pain, sleeping better. And it can cover any area. We can hit different areas. So if you say, hey, doc, I got pain in my back, pain in my thigh, pain in my left foot, we can cover all these areas. And the nice thing about the new technology, they can shoot it over different areas and have different programs. We had a gentleman speak at this conference many years ago. He had a program that he controlled from his remote. And he said, one of my settings is Disney World. We all looked at each other. What the heck is your program for Disney World? He said, well, I have a little daughter. I live in Orlando, and she loves to go to Disney World. So when I turn on this program on, I can walk a lot more. So that was his Disney World program. So you can have different programs, one for sleep, one for the day. You don't have to have it on all the time. And there's different programs. And so studies show 85% of the people respond. These are 2-year studies, pain improvement, patient satisfaction, 85%. So this is well studied. There's over thousands of people who have spinal cord stimulator. So this is not like something brand new. So you can have an app and control all of this. I know most of them, probably me, I would probably use a remote. I'm not very technologically inclined, and if you want to learn more about spinal cord stimulation, talk to your doctor, or you can go to pain.com, or talk to some of your representatives from Boston Scientific. You can meet with them, or sometimes you can talk to some of the patients who've been through this, hear their feeling about it. Okay, so I'll stop here and let Dr. Moisi talk, and I don't know. You have slides you want to share?
Well, I was actually going to just kind of add to some of the stuff you discussed.
I think I might have some of the surgical slides.
Yeah, we could do that. But I kind of wanted to talk a little bit about our philosophy and how we work so closely together, because I think that would add. So I'm Marc Moisi. I know maybe definitely a handful, if not more, of this room. So I'm a neurosurgeon. I work at a Hurley Medical Center. And, the first thing everyone's going to say is, oh, my God, he's a surgeon. He just wants to operate, right? So I have a completely different philosophy. And what Dr. Atty kind of described at the beginning is the problem of today's society. And there's just a article in the New York Times that not only did my wife send to me, but probably half a dozen other people, that we're doing too many spine fusions and too many spine operations. And the reason that we're having these problems just with chronic pain is we're not creating a team patient-centric treatment plan, right? And one of the things I love working with Dr. Atty is that you have a team, right? It's not just the surgeon working, not just the pain specialist, but we work together. And when we look at an individual, we see him a little bit differently. And what he might see might be different than what I see, and then we confer. When I see a patient in clinic, I run my practice completely different. I operate on less than 10% of my clinic, because when I see you, my goal is to never operate on you. My goal is to get you better. And what Dr. Atty was alluding to is, yes, we look at your scans, but we don't operate on scans, we operate on symptoms. And that's the most important thing, whether you come to me or not. But that's the most important thing that you need to see out there, is that someone that listens to you as a whole, examines you, looks at your scans, and as one of my mentors used to say, worst is talk to the patient. They'll tell you what's wrong with them. Because I've had plenty of patients come in and say, I don't want to talk to a surgeon, because most surgeons won't even see you unless you need a surgery. Is that not correct? I mean, there's definitely, I'm sure you've experienced this.
Oh, yeah, we had a doctor in town. I would always laugh. Until he sees your MRI, he doesn't want to see you. I said, well, MRI doesn't tell you the whole story, because you take 100 people off the street at my age and some of you guys' age, and they can have the worst MRI and have no pain. So structure doesn't always mean problem. So that's, yeah.
And I think that's very important when you're choosing your treatment team, right? We all have different abilities, but ultimately you want to be able to understand what the best treatment is for the individual. And when I see individuals in my clinic, I tell them it's patient-centric, because all of us are different, like Dr. Atty said, right? And we have different thresholds. If you have a hangnail in your toe and you're a soccer player, it'll be different than if you're someone that works with your hands. You're like, I need to get that fixed. So we need to understand what your goals are. And what you were saying with chronic pain and anxiety and the pain is in your head, that's absolutely correct. And what I try to explain to patients is your anxiety fibers and your pain fibers are the same fibers in your brain. So if I glued your feet in front of a door and I'm going to tell you, I'm going to open that door and it's going to hit you in the face, what happens? You kind of see that pain, right? You see it and all of a sudden you're like, oh my God, I've got neck pain, I've got head pain, you know. But if I tell you I'm going to move you to the side and I'm still going to open the door, but it's not going to touch you, your pain goes away. Now, did I do anything special? So our role as your physicians is to figure out exactly not only what your symptoms are, but where is that pain coming from? And is that pain coming from by looking at your MRI from a specific region, or is it something completely different? Could it be your anxiety? Could it be something completely different? Right? And what I love doing with Dr. Atty is I send my patients in when he does an injection. And I tell him, yes, it's therapeutic, but it's diagnostic as well. So for instance, if he injects L4-5, but your pain doesn't get better, well, if I operate at 4-5, it's not going to help you. At that point, I'm just operating on your scan. I'm also someone who, through the course of my practice, if your pain goes away on, let's say you do need a surgery on the day of surgery, I cancel your surgery the day of, because I can't get you any better than your own body gets you, right? So I do want to touch a little bit upon spinal cord stimulation, but first, you know, at the beginning, do you guys have any questions regarding the rest of the stuff? Just maybe one or two. If not, we could kind of continue and do all the questions at the end. So with spinal cord stimulation, just like Dr. Atty mentioned, the greatest part about it is the fact that it's the only operation that we could provide that you get to test drive before to see if it works. Because even if I do something minimally invasive, I won't know if it works. I could just predict that it will work. With this, it's pretty obvious. And in my time as, I've been doing it not as long as Dr. Atty, I've been doing it for 20 years, but for the last 20 years, it's come a long way. 20 years ago, they weren't doing diabetic neuropathy. Now there's even spinal cord stimulation that there's studies out for different reasons, including paralysis, but that's like Dr. Atty would say, that's probably another 3-4 hours of description and talking. But the key is, who are your patients for spinal cord stimulation? The only thing I would add to Dr. Atty is also maybe a patient that has a lot more medical problems that even if I might be able to do a surgery on, it's not in your best interest. Okay? Maybe you do need a fusion like Dr. Atty, but you're on blood thinners or you have a heart problem. My goal is to do, when you say minimally invasive surgery, you're going to see all those beautiful pictures online with like incisions that are this big and we did all these great things. But sometimes minimally invasive means the least amount of surgery to give you the best benefit for the longest period of time, right? Dr. Atty, respectfully, you are a surgeon because you are doing procedures that are helping people, right? So we work through this together. And sometimes the minimally invasive thing is Dr. Atty, right? Doing the injections, helping you. I tell patients, sometimes you just got to kick the can 3, 4, 5, 6 months because maybe you get through that period of anxiety and realize I'm doing better and I don't need surgery. And I'm okay with that. I've had plenty of patients come to my clinic as a second, third, fourth opinion. And like you said, other surgeons won't see them unless they have something surgical, and I remind the patient, yes, it says surgery on my white coat, but it also says MD, right? So we're here to be your physicians and part of your team. And I tell patients, even your cheerleader, right? When you're down, I'm here to encourage you to see where we could get to that next step to get you better. Let me grab.
Yeah.
Right.
Yeah.
So I'm just going to go briefly through this so you guys could actually have more, because not only is it for us to provide information, but to answer some questions, okay? So the spinal cord stimulators, there are different ways of doing it, and this is kind of the foundation of it. We could do it through wires, which is going to be the initial trial anyway. And then we make the decision, are we going to do a wire, or are we going to do a small amount of bone work called the laminotomy or laminectomy, and we slide a paddle lead. And it's going to be a little bit patient dependent, and to see, what gives you the best coverage overall. Typically, I tend to do a little more paddle leads because usually the patients that Dr. Atty and I work on together tend to be a little more complex, and they need a little more coverage to cover more areas. And what the greatest thing about these stimulators are as well is the fact that with them, once your body may get used to a certain program, because we have such a large area covered, our Boston Scientific colleagues could change them around a little bit and say, okay, maybe we could find that Disneyland for you for every day, right? So keep that in mind. And let's say you decide to get one and 3 years down the road, it stops working. Don't get discouraged. We have a lot of tricks up our sleeves. So I think we kind of went through all this. Didn't we?
Yeah. I thought there might have been some of the surgical side.
Yeah, I think that was the only surgical portion of it. Yeah. So I think the long and short of it is, for spine care these days, the most important thing is to find a good treatment team, right? Don't be dependent on one person. Find your I love PT with water therapy. Whenever I teach residents, all my residents are like, okay, the first thing Mark's going to tell you is PT with water therapy, see Dr. Atty plus minus a TENS unit. That's kind of my go-to, right? And 80% of my clinic gets better on their own. And what I tell all my patients, it's like, you're going to get better on your own, and I'm going to take all the credit, even though you did all the hard work. Because what's important is finding the right formula for each of us. And each of us have a different formula, whether it is spinal cord stimulation or whether it's us doing the work on our own. And that's what's important. And it's the most important part is finding a team that listens to you.